when you start talking about chronic disease and therapies, you're talking about money. We always come back to talk about money, don't we?
We do. But some of these therapies are very low cost. They're life-saving is what I heard. Some of them will get to Benlysta, and who's the right patient for more expensive options, but anti-malarials are fairly inexpensive.
Prevention is always going to be the best policy, isn't it? And that involves education of patients. And I think monitoring. So just as we were talking about with hemophilia in terms of monitoring trough levels, I think we're going to come to the point in diseases such as lupus of actually managing adherence by measuring blood levels of the therapies.
Okay, now we've got a lot of, I'm going to use a phrase, but I'm not sure it's accurate, treatment guidelines. I'd be willing to bet you're going to stop me and say they're just guidelines. There's ACR, there's SLIC with 2 C's,
Yes.
right? Not SLIC with a CK. There's the EULAR and the ACR. All of these are guidelines. Are they useful clinically?
These are new guidelines, by the way. We have not had treatment guidelines really in lupus, but the guidelines that are available now are 3 different guidelines for lupus nephritis. And luckily they do agree in the major conclusions that we have effective induction therapy, but where we are really ignorant is what to do with patients who fail the normal induction therapies with mycophenolate or cyclophosphamide regimens. And so what has to be built into treatment guidelines is great flexibility. And it is, I think, quite ironic that our 2 induction therapies both have to be used off-label, because neither mycophenolate nor cyclophosphamide have ever been approved by the FDA for lupus.
But why is that surprising? If lupus is a rare disease, why is it surprising that the drugs to treat it were probably developed for something else?
Well, though they were developed for something else, we actually have randomized controlled trials of these therapies showing not superiority, but often equivalence to other therapies. And this is a problem right now at the FDA for lupus. We really have to do superiority trials because we don't have a gold standard which is FDA approved.
Did they have treatment guidelines which satisfy you folks that you can say, okay, if you do this, we're going to pay for it, and if you don't do this, don't come to us?
With the generic options, we don't get to prior authorization, or there's not a lot of scrutiny that managed care is placing. And why should we? These agents may be allowed off-label, and we don't necessarily, we may not know how they're being used because they have multiple indications. If, when it comes to a very high-cost drug, then because of cost, we tend to limit the use to appropriately used FDA indications, and also to something called compendia, which is, has it been studied? Is there any clinical literature that can be supported that can justify the use of a product for a particular condition?
But they've got Systemic Lupus International Collaborating Clinics guidelines. We've got the ACR. We've got the EULAR, and I'm assuming EU is for European.
Yes.
These are all guidelines. Why can't you just use the guidelines?
Well, I would like to, because the guidelines currently for lupus nephritis do build in that flexibility, which has to be key when there aren't enough outcomes. And for example, the flexibility would include in patients who failed induction therapy for lupus nephritis being able to use rituximab. Now here, you may disagree because there have been 2 negative trials of rituximab in lupus. In spite of those 2 negative trials, we know that we can get partial responses for lupus nephritis that's failed other therapies.
How do you know? If
We
there are negative
don't know.
how do you know?
We don't.
Because
It
I'm
has
not going to
be-
let that slide. And I'm surprised you did. I mean, here we go. We have 2 negative studies, but I know because I've got my secret decoder ring told me it works. How do you know?
We do have longitudinal studies within individual institutions showing with really high-class data, such as serial renal biopsies, that individual patients can respond to off-label use of drugs such as rituximab. It has to be personalized. We do not have the biomarkers or the predictive paradigms to pick out that patient. This is lupus. We're still sort of in the dark age.
All right.
But I think to pick up on your point about personalized, that's where you don't have a blanket statement saying we're going to approve Rituxan for this off-label use. The personalization then means it may have to be a physician to medical director discussion, because that may be the exception rather than the rule. And so I think that leads to a discussion, a collaboration, and then individualization for in that patient, perhaps when other considerations have occurred, for
Yes.
that patient, it may be the right
That,
patient.
that kind of collegiality is key, but as you know, that doesn't always happen. And if we're dealing with an organ-threatening or life-threatening manifestation, the patient in the intensive care unit, for example, there's the time pressure to try to be able to start what may be an effective therapy.
Because you know, the four-letter expletives fly fast and furious on both sides of this. On one side, it's those gosh darn reimbursers need me to make 5 phone calls and this patient's sick. And on the other side, it's they want to do this again. It's going to cost us an arm and a leg, and they haven't got any proof. You understand both sides, don't you?
Of course.
Well, I think if I may jump in, I think we actually do ask questions. You mentioned the 2 negative studies with Rituxan. So that begs the question also to, since we don't really have any biomarkers to know who's going to respond, the next question we do ask is that how many people do you then need to treat to have one response? Even with Benlysta, we know that the response rate, you probably still need to treat about 11 people to have a successful response. And for Rituxan, then the question now becomes, do we have to treat 20 people? Do we have to treat 25 to have one successful outcome?